carcinoma causes SV syndrome compared to adenocarcinoma. Then coming to the lymphoma. Lymphomas, aggressively growing lymphomas definitely causes whether it is NHL or HL. That is again a question. Which of the lymphoma is more commonly known to have SVC syndrome? It is non-Hodgkin's lymphoma. Hodgkin's lymphoma, many times it presents with a mediastinal mass, but having an SVC syndrome is very rare. And Hodgkin's lymphoma, it doesn't grow very fast. That is the reason. So that collaterals develop. Non-Hodgkin's lymphoma, definitely primary mediastinal B-cell lymphoma is one cause. Lymphoblastic lymphoma. So more commonly, in my clinical experience also, I've seen many patients with lymphoblastic lymphoma, especially T lymphoblastic lymphoma. Okay, lymphoblastic lymphoma has two types, right? It's a B cell type or a T cell type. T cell type is the one which presents with a mediastinal mass, huge mediastinal mass causing the SVC syndrome, PMBCL, and other non-lymphoma cause is a germ cell tumor, primary mediastinal germ cell tumor. So if the question mentions that it is an young patient around 20 to 30 years of age with an SVC syndrome, what is a more likely cause? The cause is probably a lymphoma or a germ cell tumor. But if the question mentions just an SVC syndrome, the answer would be CA lung, that too small cell lung cancer. Okay, so we'll go to the next question. Which of the following may be associated with drug-induced pericarditis and pericardial effusion? So the topic here is the oncological emergencies. Okay. So oncological emergencies, the emergency what we are dealing with here is the pericardial effusion and tamponade. So how do we answer this question? It is definitely a memory-based question. There is nothing to analyze and think here. We need to know the drugs which cause pericarditis and pericardial effusion. So altrastranilic acid, imatinib, and arsenic trioxide, or all of the above. See, the answer is all of the above. Obviously, when you have a question like this, and if you are not sure of the answer, and if there is an option called all of the above, most of the time you select all of the above. Okay, so look at what are the chemos which cause pericarditis. Alkylating agents, so cyclophosphamide, ifosfamide can cause pericarditis. And other things are immune checkpoint inhibitors like pembrolizumab. So this is something which we routinely tell the patients. All these immunotherapy agents, they sometimes can cause myocarditis and myopericarditis. And other chemo drugs like bleomycin can cause Aracin or cytarabine. Cytarabine also causes some other inflammation. What it is? It is keratitis. So cytarabine we use prednisolone eye drops when we give high dose cytarabine to these patients, and busulfan. So these are the drugs which causes pericarditis and pericardial effusion. I'll tell you one more thing. Whenever you do a question, whenever doing tests at your home, after you find out the right answer, you also try to recollect at least 3 or 4 points about each of these options. So all-trans retinoic acid, you question yourself, what do I know about this drug? What do you know about this drug? Atra is used in acute promyelocytic leukemia. What is its mechanism of action? What are the common side effects? Okay, and arsenic trioxide, it is used in APML, mechanism of action. What are the side effects? So that is a second step after you get the answer. So that's the second step. Third step is go to the topic and read at least 3 or 4 points about the topic. So each question you spend around 3 to 4 minutes when you are doing any of these tests. So I'll go to the next question. So we'll go along with this format for the following questions. Which of the following malignancy is most likely to cause intestinal obstruction? So why does intestinal obstruction happen? So this is abdomen. There's a small bowel, and intestinal obstruction happens whether it is a mechanical obstruction or a functional obstruction. So functional obstruction cancers causing is a rare thing. So it is called mechanical obstruction. And mechanical obstruction because of the adhesions between the bowel loops. So basically there should be a peritoneal disease, omental disease causing bowel adhesions. Now come back to the options. Can ovarian cancer cause peritoneal disease? Yes. Renal cancer? Rare. Pancreatic cancer? Yes, but still rare. Cholangiocarcinoma, definitely rare. How I am saying confidently? Because I keep seeing all these patients. But how can you become confident? By reading. For the first question I told, imagine patient with ovarian cancer. Patient initially presents with a whispers in the abdomen, non-specific symptoms. That's the commonest initial symptom. Later, there is a painless abdominal distension because of the presence of ascites. Most of the patients present in stage 3. Along with ascites, there will be right pleural effusion. And as and when the disease progresses, patient becomes cachectic, develops intestinal adhesions and obstruction. And the death is because of the obstruction. Renal cancer. How does the patient present? An adult who presents with a painless hematuria. Later, there will be flank pain. And there will be IVC obstruction. So the patient later develops bilateral pedal edema. Okay. And later, bone mets, lung metastasis. Coming to the pancreatic cancer. A patient presents with loss of weight, loss of appetite, or more commonly, it is a painless jaundice, obstructive jaundice, and upper abdominal pain radiating to the back. So it is about the pancreatic cancer. Cholangiocarcinoma, it can be intrahepatic, extrahepatic, or hilar, right? Depending on the location, cholangiocarcinoma also may present with jaundice or with abdominal pain. So that is about the options. And what is the topic here? It is again intestinal obstruction, complications of cancer. So how do you treat the cancer-related intestinal obstruction? What are the causes? Apart from ovarian cancer, what are the causes of peritoneal? Most common is ovarian cancer. Second most common is the colorectal cancer. Third one is usually primary peritoneal carcinomatosis or pseudomyxoma peritoneum. And other cancers which can cause peritoneal metastasis are rare, which include breast cancer is one of the causes. Pancreatic cancer also can cause peritoneal metastasis. And how do you treat the intestinal obstruction? The drugs which are used are the steroids. Dexamethasone is used if a patient develops intestinal obstruction or subacute intestinal obstruction, along with the usual supportive care, which includes keeping the patient on nilperoral, Ryle's tube, drainage, and we give oral gastrografting. It helps us to see if what level of obstruction it is. If it is a single level obstruction or multi-level obstruction. If it is a single level obstruction, we take out that part of intestine and bring it out as a stoma. So stoma is the next treatment option for intestinal obstruction. So drug, you remember, dexamethasone is given, steroids are given. And another question, a patient with intestinal obstruction presents with abdominal pain. What drug we need to avoid? So if in normal ward, patient will also be vomiting, right? When a patient has obstruction and is vomiting, we should not give perinom, metoclopramide. Prokinetics will worsen the abdominal pain. This is another point. So the next question, which of the following urogenital malignancy is most frequently associated with urinary obstruction? So urinary obstruction, what happens? Kidney, renal pelvis, ureter, bladder, urethra. If there is an obstruction, there is hydronephrosis. The question is, which cancers we see HUN? Ovarian cancer. So remember, the kidneys, pelvis, ureter is a retroperitoneal structure. Ovarian cancer causes a lot of peritoneal metastasis, unlikely to cause a retroperitoneal involvement, except if there are retroperitoneal lymph nodes which are pressing on the ureters, which is not a common thing. Now coming to the testicular cancer. Testicular cancer, how do they present? It is a painless enlargement of testis. Only if the patient neglects, he can have a retroperitoneal nodal mass, which usually is in the center, right? It won't usually cause a retroperitoneal nodes are there, but it usually won't cause obstruction, but sometimes can be seen. I've seen many patients with a HUN. Uterine cancer. Uterine cancer is an endometrial cancer. Endometrial cancer presents in elderly ladies with postmenopausal bleeding. And if it spreads into the peritoneum like ovarian cancer. So the answer is the cervical cancer, because the ureters, after the retroperitoneum, they go into the parametrium before they enter into the bladder. So cervix, vagina, and this is the cervix. This is the uterus, and parametrium is here, right? And ureters are going like this and entering the bladder just behind the cervix. So involvement of parametrium is more common seen in cervix, which causes block of the urinary tract. So that is the reason for H1. The answer is cervical cancer. So how will you answer this question? Only if you read and imagine the patient's clinical presentation. Okay. So about the topic, urinary obstruction. How will we diagnose? Usually it is unilateral. It might or might not cause any pain. Commonly it is found in the scans. If there is a increase in creatinine, and if the treatment of cancer is not urgent, if it is not chemo sensitive cancer, we go and put a PCN or we put a stenting. So what is the treatment of HUN? Practice, we do a cystoscopy and stenting. If stenting is not possible, we put a percutaneous nephrostomy tube, especially if creatinine is increased, because long standing will permanently damage that side kidney. So coming to the next question, what is the common correct order of frequency of spine involvement in malignant spinal cord obstruction? See, there are cervical vertebra, many thoracic vertebra, some lumbar and some sacral vertebra. And cancer is not like tuberculosis. Tuberculosis, we say it is in the lumbosacral area. More dorsal vertebrae are there. It is 70% seen in the dorsal vertebrae, 20% seen in the lumbosacral vertebrae, and 10% seen in the cervical vertebrae. So the answer is thoracic more than lumbosacral, more than cervical. And what is the topic here? It is a malignant spinal cord compression. So this is again another oncological emergency. Oncological emergency, when a patient is present with a symptoms of cord compression. So what are the symptoms? It can be lower limb weakness or loss of bowel and bladder functions. In the initial stages, there can be only hyperreflexia. There may be something called a Lermit sign. When the patient bends his neck like this, there will be shooting sensations along the vertebra and lower back to radiate into the legs. That is called Lermit sign. So if any of these symptoms are there, so patient presents with a back pain, what I commonly do in my OP is I ask them to walk. If they don't have any weakness, if they're walking fine, I check their reflexes. If the reflexes are exaggerated, that itself indicates clinically that there is a cord compression. And any evidence of cord compression, what is the next step to do? Next step, we give high dose dexamethasone. I give 16 mg as per guidelines. Yeah? And then we plan for an MRI spine. Because if you delay to get an MRI spine and do not give dexamethasone, sometimes the weakness progresses very fast and the patient can become paraplegic. So the first step is high dose dexa, second is the MRI spine. And in the MRI spine, we look at whether the patient has an epidural disease or patient has a bony disease. So this is the vertebra, pedicles, laminae, and the spinous process. Spinal cord is here. So if there are epidural metastasis, that means the tumor is here, which is causing compression of the spinal cord. That needs a urgent treatment. So commonly, if it is an epidural disease, you require surgery for decompression. They do laminectomy. Or if it is a radiosensitive tumor, we use radiotherapy. So what are the radiosensitive tumors? Many times lung cancer, breast cancer, most of these are radiosensitive. You need to remember the radio-resistant. So the radio-resistant diseases are RCC, melanoma. So these are some of the radio-resistant tumors. And if it is a bony metastasis in the vertebral body and the vertebral body collapses, there may be displacement and then causing the compression. If it is a bony physical compression, it requires surgery. Otherwise, if it's just a cord compression, we require radiation therapy and then steroids will help. So that is about the malignant spinal cord. So the next question, 56-year-old male patient diagnosed with lung cancer, present with back pain for the last 1 week. Patient described pain as dull aching, moderate to severe, associated with awakenings at night due to pain. This is the classic presentation of cancer pain. On examination, he had hyperreflexia. That means cord completion is there. Extensor plantar reflex and loss of sensations below umbilicus. What is the next best step in the management of these patients? Somebody with already a neurological symptom, established deficit, should get a high-dose dexamethasone as soon as possible. So open the Harrison and see there will be a nice flow chart which gives any neurological damage. First is DEXA and then only you do the MRI spine. So you might think MRI spine to be done, but then answer is high-dose dexamethasone, remember. Then winking owl sign. So what is winking owl? I think most of you should have read it by now. This is a vertebra and this is a disc. This is another vertebra. How does vertebra look on the X-ray? It looks like this box and there will be one eye here, and there will be spinous process here. Similar, one eye, and one spinous process. So these are the pedicles. So pedicles are horizontal. So when they are superimposed, they look like a round eye-shaped structure. And if metastasis has happened in the, so this is a vertebra, pedicle, lamina. So if the metastasis has happened here, this pedicle is damaged. So we won't be seeing this white part. So we'll be seeing only one eye, nose, and then other eye is not there. Then it looks as if the owl is winking. This is called the winking owl sign, which indicates what does it indicate? Erosion of vertebral body? No, vertebral body is here. It doesn't cause winking. Interspinous ligaments are not seen on X-ray. Unilateral erosion of spinous process, this is the spinous process. It doesn't cause winking or erosion of pedicle. So that is the answer. So again, in vertebra, the meds are there. The things which you can read more are read about SINS, spinous instability in neoplasia score. So this score determines whether the patient requires a surgical fixation, stabilization or not. And then you also read about the skeletal meds. Skeletal meds, what are the drugs which are used? Bisphosphonates, denosumab, remdesivir, denosumab. So when you read a question, you read about the topic, you read around the topic also. That's how you learn more. You keep asking yourself the questions. What else to read? So which of the following is not true about seizures in cancer patients? So the first option says seizures occur more frequently in primary brain tumors than in metastatic brain disease. So I'll tell you what I usually see. All this I'm telling for you to remember. So in medical oncology OPD, we sit and see almost like 20-30 patients per day. And so many breast cancer patients, lung cancer patients. And when they develop brain metastasis, they don't present with seizures initially. They usually present saying there will be some weakness, there will be some headache, there will be some blurring of vision. And then we do the scan MRI and find out the lesions. But when a patient is referred to you after a primary brain tumor, glioblastoma, they usually go to neurologists, neurosurgeons, and then after surgery, they present to your OPD. And when you ask history, most of them would have had seizures as the initial presentation. So a metastatic brain disease, the possibility of seizures is lesser compared to a primary brain tumor. Having said that, when we see 100 patients who had seizure, and what would be the most common cause? Because the incidence of the primary brain tumors is lesser, the commonest cause would still be a metastatic disease. So the first two options, more frequently seen in primary brain tumors, but then metastatic disease is a common cause of seizure. Okay, and seizures related drug therapy may be due to irreversible PRES, definitely. So somebody who is taking treatment can present with this syndrome called PRES. This is something which you will commonly see. It is because of vasogenic edema of the parietal and occipital lobes. Most of the time, patient presents with seizure, and when you examine, there will be very high blood pressure. Then you rule out other causes, structural causes, and electrolyte metabolic causes. Everything will be normal. You do an MRI brain and see there is enhancement of the posterior part of the brain. Then you diagnose as a PRES syndrome. So what are the drugs which can cause PRES syndrome? All these arsenic trioxide, ATRA, and VEGF inhibitors. like bevacizumab, pazopanib. Most of this can cause hypertension and it can also lead to Press syndrome. So the third option is both early and late seizures are more common in posterior fossa and cellular lesions. So posterior fossa, they don't usually present with seizures. Like cerebellar disease, how many patients we have seen presenting with the seizures? Okay. So the other drugs might be hydroxyurea, also causes Press. So what are the drugs causing Press might be a question. Which drug may be helpful in patients with blast crisis in AML for preventing pulmonary or intracerebral leukostasis? So what is leukostasis? It is the counts when they reach very high levels, like more than 1 lakh or so, they will be deposited in the small capillaries in important organs in the body like brain, heart, lungs, kidneys. And when this gets deposited, there will be lack of blood flow to those organs, causes edema, dysfunction. So for the brain, patients will usually present with, might have decreased sensorium, altered behavior, drowsiness, and sometimes become comatose. Lung leukostasis causes hypoxia, breathlessness, cough, chest pain, or renal failure. So when these symptoms happen, leukostasis, it is an emergency. If the patient is definitely symptomatic, it is an emergency situation where you do leukophoresis. So you take out the blood and remove the WBC so that you rapidly reduce the WBC count. But if the patient is not very sick, what is the drug we use? We use cytoreductive chemo. What is the cytoreductive chemo commonly used? It is hydroxyurea. So why not ATRA and ATO? Where are they used? They are used in APML. Right. You need to remember what is the mechanism of all these drugs. So reading about the options. What is the mechanism of hydroxyurea? Hydroxyurea inhibits the conversion of ribonucleotides to deoxyribonucleotides by inhibiting enzyme ribonucleotide reductase, right? So the cells will not have DNA to synthesize, to multiply, so that the cells will rapidly die. So that's how hydroxyurea rapidly reduces the WBC count. Ultra-X retinoic acid, ATRA, ATO, both are used in APML. APML has a protein. What is a fusion protein? PML, RARA protein. Translocation between 15 and 17. 15 is PML, 17 is RARA. Promyelocytic leukemia protein and retinoic acid alpha receptor. So ATRA, so what happens in APML? PML RARA is a protein, right? It will go and inhibit the genes or the transcription factors. What do they do? These transcription factors will help in differentiation. So PML is a protein that is an inhibitory protein which inhibits the transcription factors for differentiation. So differentiation doesn't happen and the cells are stuck at promyelocytic stage. What does ATRA do? ATRA will go and bind to the RARA part of the PML RARA protein, and it releases the inhibition of this protein so that the cells will start differentiating again. So it will not kill the cells, it will cause differentiation of these cells. So ATRA is not a killer, it is a differentiating agent. What does ATO do? Arsenic trioxide. It goes and binds to the PML part of PML RARA. So by binding to PML, it causes degradation. This protein is taken into the ubiquitin proteasome. The sumolation is what we say. It is sumolation. Remember all these things which are important for MCQs. So sumolation, and then this protein is degraded. So when this protein is completely degraded, then the cancer is cured. Also, it causes apoptosis of the cell. So ATRA acts only by differentiation. Arsenic trioxide has two mechanisms. One is apoptosis, and there is differentiation. So at high dose, it causes apoptosis. At low dose, it causes differentiation. So the answer is hydroxyurea. Which anti-cancer drug has shown to cause life-threatening hemoptysis? Okay. So hemoptysis is usually because of the cancer. Drug-induced hemoptysis see if we remember anything about all these drugs. Ifosfamide is an alkylating agent. Do they cause hemoptysis? No. Bevacizumab is a VEGF inhibitor, vascular endothelial growth factor. So, what is it? It is a protein which is circulating in the blood, and the cancer cells will attract the VEGF and increase the neovascularization. And bevacizumab goes and binds to the circulating VEGF. The molecule level will become low, and the neovascularization is inhibited. At the same time, it will also inhibit the neovascularization, blood vessel repair in other parts. It also increases blood pressure. Because of these two reasons, it can cause hemoptysis, it can cause GI bleeds, and it can also cause or in a patient with CLD, if there are esophageal varices, variceal bleeding also is commonly seen. Somebody with HCC is planned for bevacizumab. We do an endoscopy, see if varices are there. If they are there, we band them and then only start bevacizumab. Then what about blinatumomab? Blinatumomab is a bite cell. This bite cell, bispecific T cell engager. So there is a molecule which has two parts. One part is for T cell, CD3. Another part is for B cell, CD9. So it's just a molecule which brings cancerous B cell to T cell together, so that the T cell can now kill the cancer cells. So this is the bite cell. Blinatumomab usually causes cytokine release syndrome. It doesn't cause hemoptysis. Bleomycin. What is bleomycin? Bleomycin is a very important drug for MCQ point of view. It has so many specific things. We'll discuss in detail when we discuss the class, but to briefly say, it acts in the G2 phase. None of the other chemodrugs act in G2 phase. So bleomycin acts. How does it act? It goes and binds to DNA, but unlike alkylating agents, after it binds, it will attract the ferrous group, so ferrous ion, and then generates the free radicals. The damage of DNA is because of the free radicals when you use bleomycin, and then it has characteristic flagellate rash over the skin. And there is something specific for bleomycin, which is bleomycin lung toxicity, and that happens because of low levels of an enzyme called bleomycin hydrolase. Because the levels are less in the lung, it causes lung toxicity. So why am I telling you all these things? I'm not just telling the answer. Even when you at home, if you're preparing on your own, read the question, find out the answer. Read about each of these options. At least try to remember 3 or 4 points about each of these options. And then go, what is the topic? And then read about the topic. So tumor lysis syndrome is most commonly associated with treatment of Hodgkin's lymphoma is a slow-growing tumor. No. Burkitt's lymphoma is a very fast-growing tumor, and then it is very chemosensitive. It causes tumor lysis. Multiple myeloma, usually we do not see. Chronic myeloid leukemia again doesn't cause tumor lysis syndrome. So the topic here is a tumor lysis syndrome. And how did I come to the answer? Because I know what is Hodgkin's lymphoma, what is the clinical presentation, what are the complications of Hodgkin's. So when you're reading a cancer, let us say Hodgkin's lymphoma, a picture should be there in your mind. Okay, this is how the patient presents, a young patient with neck nodes, which are slowly growing, which are waxing and waning, which might increase with consumption of alcohol, right? And then what is, once you do biopsy, this happens. If you don't treat, what is the natural progression of the disease? What should we start? What regimens we use? ABVD. What are the problems expected? Bleomycin lung toxicity. What is interim PET scan? How do you say cure? So a overall picture should come into your mind for each of these cancers, and read till you get that picture in your mind. And the topic here is a tumor lysis syndrome. Very, very important topic. We'll have a detailed class about the tumor lysis syndrome, 1 hour session. But to tell about the important points for MCQ point, you need to remember the Cairo-Bishop criteria, and you need to remember the treatment. These two are the commonly asked questions. Cairo-Bishop has a clinical and lab parameters. Clinical, you will remember. Lab parameters, I'll discuss in the next question. And then what is the treatment of tumor lysis syndrome? I think there are 2-3 questions about TLS. We'll get there. A patient with NHL is started on chemo. Pre-treatment elevation revealed elevated serum creatinine. Patient was started on IV fluids and febuxostat. Repeat investigations revealed creatinine of 1.8, uric acid is 8.4 after 2 days. What is the next step in the management of this patient? So listen carefully. I'll tell you about the lab parameters of TLS. How do you remember? So phos, O, calcium, uric acid. Phos actually rhymes with fast and PCU. Let us say pediatric intensive care unit, PICU. So go fast to PCU because a child there has a tumor lysis. This is a mnemonic. If you are able to get the picture, remember it. So fast for CU. And you remember the number starts with 4, 5, 6, 7, 8. Okay. So phosphorus more than 4.5, potassium more than 6, calcium less than 7, uric acid more than 8. Okay. So I hope all of you will now remember the lab parameters of tumor lysis syndrome. Fast, PCU. Okay. 4.5, 6, 7, and 8. And if the patient has tumor lysis syndrome, what do we usually do? We start with hydration. 3 liter per meter square fluid. We start on allopurinol. 300 mg per meter square. And we wait for 1 to 2 days. If the creatinine is less than 1.6, uric acid is less than 8, we start chemo. Okay. If the creatinine is more than 1.6, uric acid is more than 8, after 2 days, then TLS is not settled. Then we use rasburicase. So uric acid more than 8 is very high level. If it is persisting despite these measures, we need to use rasburicase. So indications of what is rasburicase? It breaks the uric acid. Okay, it breaks the uric acid. So rasburicase indications are more than 1.6, more than 8. What is the uric acid here? More than 8. Creatinine more than 1.6. So what is the answer now? Rasburicase. Okay. And when do you do dialysis? What are the indications of dialysis? So I think when you're doing MD General Medicine, you will have a fixed set of indications before you call the nephrology, right? Nephrology review. Otherwise, the nephrologist will come and scold you why you have called for dialysis. But here in tumor lysis, remember there is a very beautiful flowchart in Harrison. The indication of dialysis, you remember phosphorus, calcium, uric acid. These are the 3 parameters, right? And then potassium. So sorry, calcium is not there. Uric acid and potassium. Phosphorus more than 10. Okay. Uric acid more than 10. Potassium more than 6. So these are the indications of dialysis in a patient with TLS. Start dialysis? No, because uric acid is not more than 10. The creatinine is not more than 10. And yeah, creatinine also is one of the creatinine more than 10 is definitely an indication for dialysis. And potassium. Start chemotherapy? No, we cannot because it is still more than 1.6. It is still more than 8. Continue hydration, increased dose of febuxostat. So febuxostat is xanthine oxidase inhibitor. If there is renal failure, we consider using febuxostat rather than uric acid. So it doesn't matter because 2 days of febuxostat has not reduced. So no point in continuing. Next question. Patient with B-cell lymphoma started on chemotherapy containing rituximab. This is a monoclonal antibody against CD20. It is a chimeric antibody. After first dose, patient had a fever, chills, headache. Patient was given IV Avil. So what does this indicate? The patient is having some allergic reaction. So this is a monoclonal antibody. Antibodies are formed against a chimeric antibody. So which leads to cytokine release. Fever, chills, and headache are there. Avil is given. But then the symptoms worsen and you'll have dyspnea at rest. So this is a very significant thing. Dyspnea at rest and pain x-ray showing of fluffy opacities. Most effective considering the condition of the patient. So if you have not read, if you don't have idea about this treatment, just go and think about this option. Tocilizumab, yeah, looks possible. Dexamethasone, steroid, which will inhibit the allergies, possible. IVIG, no. IVIG is usually used if there are a lot of autoantibodies and you want to suppress those antibodies. So this is not an option. GMC is a growth factor. This is not an option. So you have ruled out 2 options, and between these 2, how will you answer? Only if you know tocilizumab acts against interleukin 6. It is interleukin 6 inhibitor. And dexamethasone definitely is used, but the patient here is very sick. So tocilizumab acts faster and better compared to steroids. If the question mentions that the patient is mildly symptomatic, persistent symptoms, but there are no opacities, then we could have used dexamethasone. Tocilizumab is used when the patient is really sick and decompensating. So what of the following is true about HUS secondary to chemotherapy? What is HUS? Hemolytic uremic syndrome. So there are vessels and there is microangiopathy, which is secondary to thrombosis. So platelets are forming clumps inside the blood vessels. What happens then? The platelet counts decrease. Next event, the RBCs are passing through these small vessels and then they're getting lysed. So that causes anemia, which is hemolytic anemia, which is intravascular hemolysis. So anemia. And then where does this happen? This happens in the kidneys. So the kidneys will have hypoxia and then there will be AKI. So HUS is a syndrome or a triad of thrombocytopenia, hemolytic anemia, and acute kidney injury. And as I said, this happens because of the platelet clumps. It doesn't happen because of the clotting mechanism. So when you use coagulation parameters, it should be normal. And usually where is it seen? Shiga-like toxin, right? Patient present with diarrhea and then present with AKA. And then you think about, oh, probably he's having hemolytic anemia because the platelets are dropping. You look at coagulation parameters, they'll be normal. And then you immediately call a nephrologist for a plasmapheresis. That's what you would have done in your MD general medicine, correct? But this is secondary to chemo. So this is slightly different. HUS occurs 5 to 7 days. This is a wrong thing. HUS occurs usually few weeks, usually around 2 to 4 weeks after chemotherapy. It doesn't happen immediately. Most patients have normal coagulation profile. Yes, that is one of the criteria. Coombs test should be negative. So the hemolysis here is because of the mechanical hemolysis, not antibody mediated. So Coombs test should be negative. And most patients survive if timely drug is stopped and plasmapheresis is started. So the chemotherapy-induced HUS does not respond to plasmapheresis, and it might worsen even if the drug is stopped. So what are the drugs which cause HUS? Remember, gemcitabine, mitomycin C, and many of these cisplatin, carboplatin, oxaliplatin. But remember, gemcitabine, mitomycin, platins. So these drugs, sometimes after a few weeks, patient will have thrombocytopenia, acute kidney injury, anemia. We think about HUS. And most of the time, it is usually supportive care, dialysis, and many times these patients become CKD and dialysis dependent. Next question. So, which are the most common primary tumor site in males causing cancer death before age 40? So, this is a very straightforward question, which is taken from Harrison table, the first chapter in oncology. The answer is the brain. So, overall, what is the most common cause of death is lung cancer. All over the world, first rank is for lung cancer. And in males, more than 40 years is lung cancer. In less than 40, if you say less than 20, it is CNS. 20 to 40, it is colorectal. We don't have colorectal option here, so the answer becomes a CNS. Okay, this is a memory question. Now, Kornofsky's index is used in cancer patients for assessment of physiological reserve and patient performance. This is the right answer. So, when patient undergoes cancer treatment, we need to know whether the patient has adequate physiological reserve, because chemotherapy itself will reduce the patient's performance status. So patient should have adequate performance status before. Karnofsky's is from 0 to 100 with 10, 20, 30 in the difference of 10. The other performance status we use is the ECOG performance status in a score of 0 to 4. Okay. So read about the performance status, which is especially ECOG performance status. You need to remember by heart. Even in sleep, you should be able to tell. Nuclear grading of cancer. So this is definitely a wrong option. What are the examples of nuclear grading for cancer? Give me 3 examples. Probably you can write in the chat box. I won't be able to see now. I'll see later. So Bloom Richardson is for breast cancer. Gleason is for prostate cancer. FNLCC is for sarcoma. FIGO is for uterine. So these are a few examples. When you read these options, you think, okay, what other questions might be asked based on these options? Index for distant metastasis in lung cancer. There is no scoring system or word for that. Predict response to endocrine therapy in breast cancer. This is based on the ERPR, right? IHC. Answer here is the option A. Again, this is a resist question. Resist is something which you need to remember very, very well. So resist is used for response to treatments. Response to cancer treatments is partial response, stable disease, progressive disease. That's all. Okay. So let us say a tumor is there. Either it should shrink, or it is increasing, or it's remaining the same size. That's about the stable, partial, and progressive disease. According to RECIST, there is two things: measurable lesions and non-measurable lesions, or targetable lesions and non-targetable lesions. Non-measurable, non-target lesions are like effusions, lymphangitis, meningitis. These are non-measurable disease. Measurable is the nodes or the masses. As per RECIST, you need to take at least 5 lesions, 5 targetable lesions, and 2 per organ. So you take maximum 5 lesions. And then what do? You look at the SLD, sum of the longest diameters. So if there is a tumor like this is the longest diameter, this is the longest diameter. You make the sum of this. Like that, all the 5 lesions. And then you make the average of that sum of the longest diameter. So it is 3 centimeters. And then later, you base the response based on the how much has reduced. Partial response means the tumor should have shrunk by more than 30%. Progressive disease means tumor should have increased by more than 20%. Anything in between is called a stable disease. As simple as that. But there is one thing which might confuse you, which is in the lymphoma. Okay. Lymphoma, what is the scoring system? Sorry, what is the criteria used for assessing the response? It is a Lugano criteria. Lugano criteria is a PET-CT based, where you look at the D score, dual score. Dual score 1, 2, 3 is metabolic CR, 4, 5 is not in CR. Okay. But Lugano also has a CT based criteria where you use something called a PPD. What is it here? RECIST has SLD, Lugano has a PPD, product of perpendicular diameters. So if there is a tumor like this, horizontal, vertical, the perpendicular diameters are multiplied and then it is sum. So sum of the product of perpendicular diameters. Here, the response, progressive disease and partial response, there should be more than 50% reduction for to say it is a partial response. There should be more than 25% increase to say it is a progressive disease. Okay. Other important aspects about RECIST criteria is the lymph node. When you are taking, you look at the lymph nodes short axis, not the long axis, and you take anything more than 1.5 as significant and more than 1 centimeter as a measurable targetable lesion. Okay, this is about the overall about RECIST criteria. So what is the answer here? Partial response means more than 30% decrease in some of the longest diameter, SLD. CA19 is least useful tumor marker for colon cancer. What is the tumor marker? CEA. Pancreatic, CA19. Breast cancer, CA15.3. Testicular cancer, AFP, HCG, LDH. In these all the options, colon also can have CA19. Breast also can have CA19 elevation. So the answer is testicular cancer. There is a very nice table in Harrison about tumor markers. You go through it in detail. So all of the following are not true about delayed MCs except. So they are asking which is true. MCs after 1 to 6 months of initiating chemotherapy is delayed MCs. No. Anything more than 24 hours is called delayed emesis. It is common and occurs after administration of most chemotherapy drugs. No. Chemotherapy drugs are classified into highly emetogenic, moderately emetogenic, low emetogenic, and least emetogenic. More than 90% risk is highly emetogenic, 30 to 90% is moderate emetogenic, 10 to 30% is low emetogenic, less than 10% is least emetogenic. And there are many drugs which do not cause very high, which do not cause vomiting. So the second option is also wrong. At this point, many patients, 90% of the patients, do not have vomiting. It is conditioned response to visual and olfactory stimuli previously associated with chemotherapy. No, this is called anticipatory emesis. Delayed emesis could be controlled with oral dexa and metoclopramide. This is the right answer. So emesis, acute is less than 24, delayed is more than 24. And how do we treat or prevent emesis? We use 3-drug regimen, 2-drug regimen, and 1-drug regimen. For a low emetogenic risk, we use only one single drug, which is typically 5-HT3 antagonist, ondansetron, palinosetron, granisetron. If it is moderate emetogenic, we add dexa, the 5-HT3 antagonist. And if it is highly emetogenic, we add NK1 antagonist, neurokinin 1, which is aprepitant and fosaprepitant. And then the 4-drug regimen, again for very highly emetogenic, the 4th drug has, 4th drug is the olanzapine. This is briefly about the chemotherapy-induced emesis. Read about the drugs and their side effects in detail. So you need to know what is the side effect of palinosetron, what is the side effect of aprepitant, what is the mechanism of action. Overall, which cancer has the highest incidence worldwide? Highest incidence worldwide is the lung cancer. So this is according to the Globocon data. So Globocon data, lung cancer is the most common cancer worldwide. We had put a Lancet publication in the NEET WhatsApp group. So that is a very, very important document. Go through the document in detail. See what are the common cancers, what are the countries which are where the cancer is common. See if there is any abnormal or specific things. Let us say Northeast India. Which state in Northeast India? Which cancer in Northeast India? South, which is most common. South versus North. Rural versus urban. Smoking versus non-smoking. Incidence. So first 2-3 cancers, male versus female. So make a note of all these points and read that publication we had kept in the WhatsApp group completely. Which of the following best describes progressive disease? I just told about this question. Probably you can answer on your own. Any new lesion, irrespective of size, is definitely a progressive disease. New lesion more than 50%? No, the answer that is 30%. That is more than 20%. And at least 15% increase in sums of the perpendicular diameters. No, again, this is wrong. It is 20%. Rising tumor markers doesn't come under RECIST criteria. So the answer is appearance of any new lesion irrespective of the size. 50-year-old female with invasive breast cancer is on neoadjuvant chemotherapy. After 6 cycles, repeat MRI was done to look for tumor shrinkage, which showed a 25% of decrease in sum of perpendicular diameters. What will be the response called? So to say it is a partial response, there needs to be more than 30% reduction. Sorry, pencil is not working. So I'll just tell from here now. More than 30% is a partial response. So here it is a stable disease. Answer is stable. Neutropenic enterocolitis is the inflammation and necrosis of the intestine which may complicate treatment of acute leukemia. Which part of intestine is classically affected most commonly? So when a patient is there in the ward, induction ward, and patient starts having semi-solid stools, I'm very much worried. I go and palpate the abdomen. I specifically look at the right iliac fossa. I look at the cecum, that is a typhlitis. Cecum is the most common site of neutropenic enterocolitis. Persistent hypoglycemia may be seen in large mesenchymal tumors other than pancreatic islet tumors. So what is the cause of malignant or paraneoplastic hypoglycemia? Commonly is the insulinomas, right? So mesenchymal tumors also can cause secrete incompletely processed IGF, which activate insulin receptors. Which IGF? This is a memory-based question. The answer is IGF-2. Which of the following is not true for classification? So remember, pneumonic, what is it? Fast PCU, right? Pediatric intensive care unit. So FOS is 4.5, potassium is 6, calcium is 7, uric acid is 8. So everything is correct except for option A. So that is a wrong option. So what of the following inhibits PIK3A? So it's not working. So PIK3A. So after this today's discussion, you do one thing, open the pathways chapter, cancer cell biology in Harrison. There will be a big picture where all the pathways which are involved in cancer will be given. So there will be epidermal growth factor at the top. From there, one pathway is a RAS, RAF, MEK, ERK pathway. Okay, that is an important pathway you need to know. The second pathway is a PIK3 AKT pathway. So PIK3 AKT pathway. So which of the following inhibits PIK3CA? So PIK3CA, if it is mutated, causes persistent activation of the transcription factors, leads to cancer. Commonly seen in breast cancer, endocrine positive patients, and other cancers also. Alpelisib is a PIK3CA inhibitor. So I told PIK3CA has, the next part is a AKT, right? Many times when we inhibit PIK3CA, the AKT will become overactive. Okay, so that's the mechanism of resistance of the PIK3CA agents. So a new molecule has been invented, which is a capivasertib. It is a pan-AKT inhibitor. Okay, so PIK3 pan-AKT inhibitor capivasertib. The peculiar feature of these two drugs is a hyperglycemia. So when a pediatric oncologist hears alpelisib, he will think of hyperglycemia, which is very bad. Sugars go up as high as 400 or 500. And most of the times we stop the medicine because we are not able to control the sugars. But why does it happen? Because insulin also acts through PIK3CA pathway. So insulin binds to insulin receptors. The downstream path includes PIK3CA, AKT, followed by the transcription of factors which are for GLUT4. So GLUT4 goes to the surface of the cell and takes up the glucose, right? So when this pathway is inhibited, the GLUT4 doesn't come. The sugar has no way to enter, and also because of the lack of feedback, the liver produces more and more sugar, glyconeogenesis and glycolysis. So the sugars become very high. So the treatment of choice for PIK3CA inhibitor induced hyperglycemia is metformin and dietary restriction, and later we can use pioglitazone. Okay, and belzutifan. You read about belzutifan, which is very interesting drug, which is used in von Hippel-Lindau syndrome, which happens because of increase in HIF2 alpha, hypoxia-inducible factor. VHL syndrome has HIF2 alpha, which leads to generation of cancer. And belzutifan goes and binds to the HIF2 alpha and inhibits it. So this is used in renal cell carcinoma, especially VHL syndrome. Ivosidenib. Ivosidenib is a IDH1 inhibitor. So what is IDH? Isocitrate dehydrogenase. So all these are the things which you need to remember, read, and again revise, discuss with your friends. And whenever somebody asks, you should be able to tell 4 or 5 points about any of these drugs. That's very important from the exam point of view. Each drug you need to know what does it do, what are the common side effects. That's all. Okay. So ivosidenib is a IDH. What is IDH? Isocitrate dehydrogenase is seen in Krebs cycle. Krebs cycle converts alpha ketoglutarate to what is it? Normal, but abnormal alpha ketoglutarate, IDH, isocitrate dehydrogenase converts alpha ketoglutarate to 2-hydroxyketoglutarate, and then it causes epigenetic changes in the DNA. So these epigenetic changes lead to development of cancer. So ivosidenib acts at the epigenetic level. It also causes differentiation syndrome. That's one interesting point about ivosidenib. So coming to the last question, loss of CDKN2A. What is it? Cyclin-dependent kinase. Function in melanoma predisposes to cancer development primarily because. Okay. So the cyclin-dependent kinase, what does it do? It is involved in the cell cycle, correct? So this question might look very difficult. So some of these googly kind of questions do come in the exam, but then you go through the options carefully and think you can rule out. So first option, read. It leads to overactivation of telomerase. Telomerase has nothing to do with the cyclin-dependent kinase, so that might not be the right option. RB and P53. if you have read Robin second year and MD General Medicine, you will definitely remember RB and P53 come in the same page and same diagram as a cyclin-dependent kinase. So even if you don't know about melanoma pathogenesis, you should be able to select the option B. Melanocortin receptor. So melanocortin is a nuclear receptor, right? It has nothing to do with CDK2A. And it enhances signaling. So CDK is not involved in the signaling. It is involved in the cell cycle transcription. It causes increased transcription of MITF oncogene. So it is not very specific. Cyclin-dependent kinases are very general for most of the parts of the cell cycle. Okay, and you also read about the cell cycle. So how does cell cycle happen? So let us say there is a DNA, and DNA has a, for DNA multiplication, we need a protein called E2F, elongation factor. If elongation factor is blocked, DNA doesn't multiply. Why is it blocked? Because of RB, retinoblastoma protein. And as long as RB is binding to ETF, it is not multiplying. So how does RB is taken out? When we give phosphorus to RB, RB leaves ETF and takes phosphorus and goes away. So what is the enzyme which gives phosphorus? It is called kinase. And what are these kinases dependent on? Cyclin. So they are called cyclin-dependent kinase. So cyclin-dependent kinase, phosphorus is given to RB, RB leaves ETF, ETF is free, and now it elongates the DNA, causes cell cycle. So RB is a tumor suppressor gene. Where does P53 come? So these cyclin-dependent kinases are kept in check by some of the proteins, commonly P16, P21. These are the proteins which inhibit the cyclin-dependent kinases. And these proteins are produced by under the guidance of P53, that is the guardian of genome. The big guardian of genome, which will keep looking for the DNA damage, any stressor or pathway, which includes Catch1 and ATM, anti-injection, telangiectasia, mutated protein ATM pathway, will cause P53 to become activated, which produces P21 protein, which blocks the cell cycle. So that's how it guards the genome from multiplying abnormally. And P53 is kept under check with MDM2. So this is the diagram apart from the previous pathways I told, which all of you need to remember by heart. Okay, that is the answer. So that finishes the last question. So I'm stopping the slide presentation. Stop sharing. Yeah. So if somebody can put the questions which are put on YouTube here, we'll answer and then we can finish off the today's session. Hello?
Yes, sir. Sir, as of now, no questions.
Okay. Okay. So we'll end the session?
Yes, sir.
Oh. Thank you.